I'm Dr. Amber, and today we're going to review everything you need to know about hearing loss and vertigo for NCLEX. Before we jump into interventions, let's talk about types of hearing loss, because interventions are based on the cause and location. Conductive hearing loss is usually temporary and caused by obstruction to the middle ear by something like earwax impaction or damage from otitis media, or even a tympanic membrane perforation, also known as a ruptured eardrum. Remember, although conductive hearing loss typically resolves when the underlying cause is treated, sensorineural hearing loss is permanent. And that's because this is damage to the inner ear or auditory nerve from aging, noise exposure, Ménière disease, or even ototoxic drugs like furosemide. And clients can even have mixed hearing loss, which is a combination of both. NCLEX will start with prevention because a lot of hearing loss is avoidable. We must teach clients to protect ears from excessive noise. Clients should wear earplugs around loud sounds, and they should avoid loud volumes. Clients should also avoid cleaning ears with cotton swabs because this can actually push wax deeper into the ear canal and lead to an earwax impaction. And finally, they should avoid placing sharp objects in the ear because they can actually perforate that tympanic membrane. If the client has hearing impairment, the NCLEX expects you to understand how to effectively communicate with them. And I know this seems basic, but this is the type of stuff that's going to show up on the fundamentals or basic care and comfort section of the exam. First, we must face that client when speaking slowly and clearly using simple sentences. And remember, do not raise your voice or shout. It actually distorts sound, making comprehension more difficult. Instead, use a normal lower-pitched voice because high-pitched sounds are lost first with sensorineural hearing loss. We should also use communication boards and written instructions as needed, and encourage the client to use hearing aids if they have them. Finally, we need to implement environmental changes to improve communication. We must ensure good lighting for lip reading, and we must reduce background noise, like turning off the TV when talking with the client. So now it's time for our first NCLEX quick check. Pause to answer the question. You should raise your voice when speaking to a client with hearing impairment. True or false? False. Remember, raising your voice or shouting distorts the sound and makes comprehension more difficult. Instead, speak normal or use a lower-pitched voice and talk slowly while facing the client. What environmental changes improve communication for hearing impairment? Decrease background noise, like turning off the TV when talking, and ensure the room is well lit to allow the client to read lips. Now, let's talk about hearing aids. First, we have an earpiece that fits either behind the ear or in the ear, and the job is simple. It just amplifies sound. That means it makes sound louder, so it can be used for many types of hearing loss. Next is cochlear implants, which is a surgically implanted device that bypasses damaged inner ear structures and directly stimulates the auditory nerve. That's why cochlear implants are used for severe sensorineural hearing loss when hearing aids are no longer effective. So when clients first start using hearing aids, they can take some getting used to. So we must perform client teaching. They should start by wearing them in a quiet environment with the volume low, and then gradually increase the volume and wear time to reduce frustration and allow the brain to slowly adjust. Clients should also be instructed to change batteries regularly because batteries typically last about 1 week. They should also turn the device off when it's not in use to save battery life. And for cleaning, clients should keep it simple. Use a soft brush or toothpick to clean the ear mold. And finally, the client should store it in a cool, dry place to protect the device. Cerumen Impaction is wax buildup that blocks the ear canal. And because sound can't get through, it can cause conductive hearing loss. So how do we treat it? Well, we typically start with eardrops to soften the wax or perform gentle irrigation of the ear canal. But NCLEX has some hard stops here. Never irrigate if there's a suspected tympanic membrane perforation or infection like otitis media because it can cause injury or worsen the condition. And finally, do not irrigate if there is any type of vegetative matter like beans or pasta in the ear. Think pediatric clients, because irrigation can cause the objects to swell and actually worsen the impaction. If we have to perform ear irrigation, the procedure matters. We should start by positioning the client sitting or lying down with the affected ear up. And always place a towel or basin under the ear. Next, we must use body temperature irrigation solution. If it is too hot or too cold, it can stimulate the inner ear and trigger vertigo or nausea. Before irrigating, position the pinna to straighten the ear canal. Pull it down and back in children under 3 and up and back in older children and adults. We must hold the irrigation syringe about 1 centimeter or half an inch from the ear. And here is the NCLEX safety rule. Aim toward the side or top of the ear canal and irrigate gently. Never aim straight at the tympanic membrane because it can cause injury. And finally, you must stop immediately if the client develops pain, dizziness, or nausea. That's a sign that the temperature or pressure is unsafe. And if we continue to irrigate, we can cause severe vertigo, increasing the risk of injury for the client. So now it's time for our next NCLEX quick check. So pause to answer the questions. What teaching should the nurse provide for hearing aids? Gradually increase volume and wear time when clients first start using a hearing aid to allow time for adjustment without frustration. And clients should change batteries regularly. Finally, the client should clean the ear mold with a soft brush. Ear irrigation is useful to treat otitis media. True or false? This is false. We should never perform ear irrigation if the client has a suspected infection or perforated tympanic membrane because it can cause injury or worsening of the condition. What findings require the nurse to stop ear irrigation immediately? Pain, dizziness, or nausea, which indicate a problem with temperature or pressure and increase the risk of vertigo and injury. So now let's talk about a couple of common ear surgeries you may see on NCLEX, like tympanoplasty, which is repair of a ruptured eardrum, or a stapedectomy, which improves hearing for clients with otosclerosis. But proper postoperative care following ear surgery is essential to prevent complications. First, position the client with the operative ear up and monitor for excess drainage, which can signal complications. If excess drainage is noted, we must immediately notify the healthcare provider. Next, and this is key, avoid any activities that increase ear pressure. Because pressure changes can worsen vertigo, that means the client should avoid air travel and they should avoid bending, lifting, straining, and sudden movements. Clients should also blow their nose gently, 1 nostril at a time with their mouth open. And finally, clients should use stool softeners to prevent straining. So if you remember one thing for NCLEX, protect the ear postoperatively and prevent any increases in pressure. So now let's talk about vertigo and Ménière disease. Vertigo is caused by inner ear disease, and instead of just dizziness, clients will often feel this miserable spinning sensation. That spinning leads to nausea, vomiting, and greatly increases the risk for falls. So safety is a top priority. Ménière disease is a specific type of vertigo caused by chronic fluid buildup in the inner ear. That excess fluid can trigger severe vertigo and even drop attacks, where clients suddenly fall down without warning. Other findings of this fluid buildup in the ears include tinnitus or ringing in the ears, a feeling of fullness in the ear, and over time, gradual hearing loss. So, the number one priority with the vertigo and Ménière disease is safety. These clients feel like the room is spinning, so they are at high risk for falls. And that's why we should teach clients to avoid sudden movements. So for example, they should turn their head really slowly. We should also implement fall precautions. And during a vertigo attack, the client should sit quietly in a dark room. This decreases sensory input and helps calm that vestibular system. Clients should also avoid standing on chairs or ladders because sudden changes in head position can trigger a vertigo attack. So let's talk about symptom management for these conditions. We give antihistamines like meclizine to decrease vestibular stimulation and improve vertigo. And if nausea or vomiting occurs, antiemetics such as ondansetron or promethazine are administered. And for Ménière disease specifically, teaching focuses on fluid control. A low-sodium diet and diuretics decrease fluid buildup in the inner ear, which helps reduce vertigo frequency and severity. So now it's time for our last NCLEX quick check. So let's pause to see if you can answer these questions. What positioning and activity restrictions should the nurse teach a client after ear surgery, like a tympanoplasty or a stapedectomy? We should position the operative ear up and monitor closely for excess drainage and avoid air travel, sudden movements, and straining because we want to avoid any activities that increase ear pressure. And finally, what safety teaching should the nurse provide to a client with vertigo to prevent vertigo attacks and injury? They should avoid sudden movements and standing on chairs or ladders, which can trigger dizziness. And we must implement fall precautions to reduce injury risk. So now you are ready for questions on hearing loss and vertigo when taking the NCLEX.